welcome everyone, and say thank you to everyone who could make it here this evening. A special thank you to the third-year residency class that put together the talks and reviewed the articles for tonight. And I want to thank Smith & Nephew as well for helping to sponsor this educational event. I want to thank Gordon Hunter also for making a special trip out to talk to us about a pertinent topic related to sort of the core theme of tonight, which is alternative bearing surfaces and arthroplasty and some controversies in bearing surfaces and modularity. So with that, we're going to start with a meta-analysis and systematic review of all polyethylene tibial components. It's going to be presented here by Dr. Schlepp with the accompaniment of a case related to that topic.
Hey, Adam.
Yeah.
Can I say one thing? I just want to thank first of all, thank Adam for putting this together and organizing it. I think it's great. I think it's great for our department. I want to thank all the residents for putting together the work, putting together the presentations, and reading the articles. I think this is really great for your kind of education residency experience. So thank you, Adam, for the invite, and thank you, residents, for putting all this stuff together for the work. Okay?
You bet. So we'll start off with all polytibias. Some of this is going to be a case presentation and then a brief review of that. And then there's also some other slides in here because I did this presentation when I was at Northwest. So they kind of just got folded into an old presentation. But so we're going to the patient we're going to talk about is a 58-year-old male. He works as a marine mechanic. He has ichthyosis, which was interesting, and actually pretty much all throughout his entire body. But yeah, scaly like fish. And he was a previous heroin abuser, which actually played a role in his kind of post-operative outcome. But he was a non-smoker, skinny guy, non-diabetic, and he had chronic, very severe left-sided knee pain. Here's preoperative films. Pretty significant arthritis, particularly in the medial compartment, and lots of osteophytes, particularly anteriorly, but also posteriorly. Here's an intraoperative film for him. So we decided to go with an all polytibia, partially out of interest. But we did a CR, and intraoperatively it went pretty smoothly. We placed the tibia first, which we'll kind of talk about very briefly, then placed the femur. Really good stable knee. It's post-operative x-rays, which are pretty good with tibia bears. So these slides were in from a different talk, and I'll just do them really quickly. But basically, all polytibias really started with the beginning of all total knee replacements. The first total knee replacements were all polytibia designs, starting in the 60s. In the 80s, they came out with these what we mostly do now, which are modular back middle components or monoblock components, and that the thought in that really took off in the 80s after this paper by Insall and Bartel, which showed that the stress transfer to the tibia was better with a metal backed tray with a peg design. It also provided some other advantages. Modularity in the operating room is one of them. The potential to exchange it, like for a poly exchange being another. And then things that we don't think about, but inventory reduction. You don't have to have a million different large implants around to size everybody with different poly thicknesses. Just briefly, pros and cons. So one of the major pros is that you can preserve much more tibial bone because you don't have to accommodate a tray to have the same amount of poly thickness. The other is the cost, which I'll talk about briefly. Cons kind of talk about the modularity, revision options, because you can't just take in and out and upsize your poly if you need to. This idea of load transfer, which I might talk about a little, I might take that slide out, and then the technical issues with placing an all poly tibia, which makes it a little bit more difficult. One of the kind of interesting considerations is, although the Insall paper shows the load transmission to the tibia to be superior, there's some theoretical advantage of having polyethylene to cement interface because the stiffness of the two interfaces is much more similar to each other. Where if you have a metal to cement interface, the metal is very stiff, and if there's going to be any shear, it'll be absorbed or it'll be transferred through that interface much more quickly. The thought of this would be that then the cement and polyethylene interface can actually absorb some of the shear. I don't know if this has been proven or and it's definitely not been shown in any sort of actual clinical study to make any difference. There's also this concept of backside wear, which is wear between the tray and the polyethylene component, which is probably a real phenomenon, but again, we don't really know exactly what that means. The surgical considerations are definitely probably the main reason at this point that we don't use all polytibias as much as we use the trays. Part of it's surgeon familiarity. The other part is that it's just a little bit harder and you have to be really more comfortable with placing your tibia because you basically buy it. The other thing is the order of implantation. So this is something we talked about quite a bit for our case. We elected to do the tibia first. The issue with doing the tibia first, particularly if you have a posterior stabilized or any other more constrained device, that stem is now sticking up in your face and you have to get the femur around it, which can be done, and we did a PS tibia. You just have to account for it. Make sure you have the exposure to get it done, and then tourniquet management, because once you have the tibia down, you really can't get to the back of the knee if you want to get to the back of the knee. So this is the paper that we were going to review. New to paper, it's a systematic review and a meta regression. It's quite the intense document. But they ended up reviewing 27,000 all polyethylenes and then about 10,000 fixed bearings in the studies that they reviewed. Oh, this is my cost slide that got saved. It's cheaper. If England, if they switched to half, they'd save $40 million. That was in 2004, so they'd probably save about twice that now. These are the major results slide from the systematic review. You can see that this is just revision for any reason, and kind of everything falls right down the middle. This is an interesting slide, which they like to talk about a whole lot in this review, is that if you actually graph these out over time, that there's been a kind of gradual trend towards favoring all polyethylene components, and there's a lot of theories about this. One being that these components in the early 70s and 80s were early type of designs compared to not quite more modern designs, as well as the change in polyethylene as we've moved along. These are the knee society scores. Again, you see that basically everything's falling right down the middle. And that's the vast majority of the conclusion of the study is saying that there's basically no difference when you look for clinical outcomes. There's possibly a trend towards favoring all polyethylene tibias as we move forward in the future. We're not exactly sure why that is. And that if you're comfortable doing the technical procedure, that it's definitely a reasonable and viable option.
So I use a lot of all polytibias now. I've been trying to do them for the majority of my total knees. My rationale for that, number one, is a cost issue. I think given the increasing cost of medicine, I feel very strongly, especially with bundled care packages, in terms of what we're seeing in terms of reimbursement. You can save money on the front end, on your implants. It's better for the hospital. It's better for the healthcare system, and so I find it to be a lot better if I can save $1,000 a case, not putting in a base plate. This paper did an excellent job, I think, in terms of the scope of the meta-analysis. It included papers not only from the United States that were written in English, but also papers from other countries. They utilized like 5 or 6 different databases. It was very extensive, well done meta-analysis, and the statistical analysis that was done in the study I thought was fantastic. But in addition to the cost savings, I think that clinically it does, at least based on this data, it does as well or better than metal back components, especially when you look at more modern implants, which is what I use. I think the backside wear thing is real. You get a thicker poly, which I think is a benefit. You take away less bone. It's very easy to revise an all poly component. If you have to revise one, you just cut through the peg and you're done, and then just take a burr and So you save a lot of bone if you have to revise these, which I think is a big benefit as we're doing total knees in younger people. And some of the supplemental papers that I let you guys read or sent to you guys were that if you look specifically at early failures, the all poly tibias outperform the metal bagged tibias. So I agree, it is a little bit more technically difficult to do, particularly a PS when you have to cement over the post. But I don't think that's a reason to not do it if you should learn to do it. But those are some of my thoughts.
So I use metal back components for all cases, and part of that really is, I think, surgeon familiarity. Ultimately, the goal of any tool arthroplasty is to kind of restore the mechanical alignment and the sagittal corneal balancing. All those things play into longevity, probably more so than mechanics to a large degree. But I mean, most of us don't train on polyethylene total arthroplasty, so I think part of that is, to your advantage of that and being here, I think you probably learn some of the nuances of doing this technique. Obviously, you can't argue with the data as much as I'd like to. I mean, analysis is kind of obviously that's first level evidence, and registry data also supports it. So I think to some degree it's surgeon preference. You talked about the pros and cons, and obviously I think there's some pros with modularity that you may not have with the versatility of all polyethylene trays, but that may change as the surgeon use goes up. So it's probably going to cross the point at some point. A lot of what we do in orthopedics is just based on what our mentors did and what that guy Install did, and Bob Moore and a couple other guys that really advocated for modularity and metal back trays. So I think it's the impetus is on us to criticize what we do, and I do applaud Adam on kind of thinking outside the box, because I really think that a lot of us do get kind of trapped into what we know and maybe not analyze it as critically as we have in these papers. So hopefully you guys will be able to see both techniques and make a decision in terms of what you feel.
Ultimately, though, I think moving forward with your careers, you have to do what you do best. So there's plenty of data that suggests patients do really well with total hip after femoral neck fractures. But if you don't put in a lot of sockets, like I wouldn't start doing it for femoral neck fractures. So if you don't do, or you don't feel comfortable doing all poly tibial components, like I wouldn't just start doing them, unless you receive some sort of training or, get some experience doing them, whether it's in a cadaver or whatever, to learn the nuances of cementing them and that. So, I think that ultimately we want to take the best care of our patients, and so you should do whatever is going to enable you to do that. All right. So maybe, questions?
Yeah. So, so if you're doing a lot of all poly tibias, is your new baseline to say, okay, I'm going to go in a case, like if it's a primary knee and I'm not expecting to need any additional degree of constraint beyond like a PS knee, to say, okay, like I'm going to go in expecting to do an all poly tibia. What is your sort of algorithm then for bailing on that? Like at what point are you going to start thinking about like, okay, well, like I plan to go in doing all poly tibia, but maybe like I'm having trouble balancing the knee, and I want to switch to something more modular so I can change.
Yeah, so if I need a stem, if the bone stock's extremely poor, where I feel like, gosh, I want to put a cemented stem here just because I don't trust the bone, like if it's a post-traumatic situation or very osteoporotic tibia or femur or whatever, that'd be one. Two would be if I needed extra level of constraint past PS. Three, there's some size considerations on all poly tibias. So, for instance, like if you're going to use a size 15 insert, you're out if you have a PS knee on an all poly. I think the most it goes up to, at least the system I use, which is the Legion system, you can get a 13 millimeter all poly insert with a PS. After that, you're using a base plate. And then the fourth thing would be if, when I was getting in my trialing, it was really difficult to get the liner in that I wanted, because I've had a couple cases where there's been sort of lateral subluxation of the tibia relative to the femur, and it's been a little bit difficult to get in my poly just on the trialing, during the trialing phase, So I know that that's going to be a little bit difficult to work around when I'm dealing with cement. And so those are sort of the main times where I'll bail to using a modular base plate.
Do you feel like if you're trialing and it's sort of between sizes, you're still willing to sort of choose
I'm never
a size?
between sizes. So I usually make my mind up. Like if you're undecided, spend 2 more minutes trialing and make a decision. So, I did one of the main reasons that I went to doing all poly tibias is because in my fellowship, I worked with a guy, Ryan Nunley, who was very good and very fast. And what he would do is he would make up his mind, he'd put in his tibial base plate, open the real poly, put it in while he was, cementing, before he cemented the femur. And then he would let the cement cure with the real insert in there. I'm sitting there watching going, well, if we're just doing that, and we're buying it right out of the gates, and we almost never, I think maybe one time my whole fellowship year, I ever see him go, oh, this feels a little bit loose, maybe I should go up a millimeter or 2. I mean, it just doesn't happen normally. And so I felt like, well, if we're doing this out of the gates anyways, why not just open up the all poly tibia and start doing it that way? So, but yeah, I usually I spend a fair amount of time trialing and then I'm sure.
Is it a pretty easy transition from all poly to putting in a metal back plate intraoperatively if you need to, or do you burn any bridges switching from poly to metal back plate intra-op?
What do you mean?
Deciding at some point that you're not going to do a poly and switching to a metal back.
No, because the trial is the same exact thing.
So it's pretty easy to do.
Yeah, and especially with the system I use, you can add stems and you go constrain without doing much. So.
And in the Newton paper, the only thing that was significant, which was range of motion, their motion total, or maximal total point motion, was based on 3 papers with really small ends. Have you subjectively seen any difference in your base plate versus?
No, not in range of motion. Yeah. Well, the one thing I found interesting in the meta-analysis too was that all that biomechanical data on transfer is better with metal back tibias. I felt like that's not really clinical data because that was all biomechanical data. But if you looked at the clinical data from the studies, there was actually a higher trend towards subsidence of the metal backed tibias and change of position based on the radio, that RSA analysis. I don't know, but anyways, let's start talking about dual mobility. Who's got the
real quick?
Yeah.
Let's get some food real quick before it
Sure.
gets cold.
Okay.
Just take a quick pause.
The reps need it all.
It's good. Are you good? Drink some water, man. Having a glass of wine. Yeah.
I still think you have to be critical of component position. Again, what problem are you trying to solve? Instability, is that a real problem? It is. In the Medicare database, it's the #1 cause for revision, so that's not a problem that one can ignore. At the same time, the causes for instability are #1 and #2, component position, typically acetabular component position in particular, and abductor tension. Those are not problems that are solved by a large head. And I don't think a large head could solve those problems. So ultimately you have to be critical in your technique. There are some problems that are very difficult where I think this is a very good alternative, particularly to a constrained liner. So revisions, particularly for stability, and there's data that suggests that this implant can solve problems that a constrained implant cannot. It decreases some of the complications that constrained liners have, which are common. Constrained liners, if you're looking at the same population, have probably a cumulative complication rate of around 20%. So that's the standard for revision for recurrent instability. I think is a good alternative. So at least in my hands, this is my #1 indication to some degree. At the same time, I do use these for primaries in some circumstances. Particularly the design system I use, which is a hemi-elliptical cup, I can use a 50 cup and still get around 6 millimeters of polyethylene with a 36 millimeter head. If you look at the sizes of heads, I think between 36 and 28 in particular, there's a real mechanical difference in terms of the stability one can confer, jump distances, and range of motion to a pinion. So, at least in my hands, if it's less than a 50 cup, I think rather than compromising in terms of thermal head size and polyethylene thickness, I think you can use an MDM or a polar cup or one type of these dual mobility type of constructs, and minimize the compromise they have to make between polyethylene thickness and thermal head size. So I think those are the two major indications. I think, like everything else, the data suggests that these implants are used a lot, probably a lot more than they probably should be. So I think that would be the take-home message: is to not rely to some degree on these implants in order to solve problems that doesn't exist. I think the current indication really for this technique is to solve a problem for instability, and then as safety is demonstrated, we may be able to expand our indications.
So I would echo a lot of that. I think for me, I think of dual mobility as having a sort of narrow indication currently. So primary situations, I use it in a situation that I think they're going to have an increased risk of instability even with well-placed components. So conversion of an IM nail, is a good one because you have the damaged gluteus medius insertion with troch entry nails, and there's plenty of data to support that conversion from an IM nail to a total hip has a much higher rate of dislocation. So I think that's a good indication. I did a case with Connor on a guy that had a posterior wall fracture that had been dislocated for 6 weeks while his column was healing. We used dual mobility because he was chronically dislocated. So that guy has an increased risk of dislocating. So, people that have neuromuscular disorders but have an intact abductor, I will use it on. But I think the requirement should be that they need to have an intact abductor. I think if they don't have an intact abductor or they have an absent trochanter, then really you should be looking at a constrained liner rather than a dual mobility cup. I don't think this is a good cup to put in all your primaries. I think just like metal on metal, you have a false sense of security thinking that you can answer every problem with this rather than, as Navin said, focusing on the position of your acetabular component, your femoral component. What you don't want to do is, now, just like metal on metal, we had a bunch of guys putting in cups that, because they felt like they could rely on the head to protect them from dislocation, putting in vertical cups. And then what ended up happening? You edge load a metal on metal bearing surface, and you got catastrophic wear. And we don't know what a dual articulating surface on polyethylene is going to do in terms of generating polyethylene wear particles, especially if you put a cup in vertically, because you're relying on this head to give you all your stability. So, I think we don't want to trade one problem for another problem 5 or 10 years down the road. So I'm very judicious with my use of this implant. I think it does have a certain place, and it is useful in certain circumstances, but it's certainly not my go-to. And then, with respect to use in revision, I think it's very helpful, especially if you're revising metal on metal components that have been placed for to prevent dislocation. Now you have someone that's had a 50 head in there for a while. Let's say they had a really long neck, and now you want to take away their metal on metal bearing surface and just convert them to metal on poly or ceramic on poly, and now you're giving up a ton of stability by downsizing their head. So in those people, particularly if the cup is not in a good position, I'll think of revising it to either an MDM or another type of dual mobility component, so that I can get that bigger head back in there to protect them from dislocation. Dr. Fuchs, what do you use these much, or?
Not very often. Primarily only in revision situations. I've contemplated using it in oncologic situations, so that's kind of a major part of my practice. I've done hundreds of oncologic implants, and it seems like like you said, without an abductor, if you don't have abductors, you use constrained implant. And interestingly, my colleagues in the Musculoskeletal Tumor Society have taken a long time. So I've been using those for 20 years. But you do, as was mentioned, those fail. I mean, they eventually fail. and these people are living now that didn't live before, and so these oncologic implants, the kind of straight ones fail. So, the concept I think has just been, I've only been using it for revision situations.
So even, again about pushing the limits, there's a paper that was presented at this CCGR meeting for Rush. Craig Del published a lot on this topic, particularly you may have an invested interest, I don't know, but they're publishing on their series of revision of constrained minors for abductor deficiency with dual mobility, and at least the early data suggests that the rate of failure is low. So, I mean, with some of these dual mobility concepts, you can get a 70 head or something. It's insane. So just by overwhelming the mechanics of the acetabulum, increasing the jump distance, may be sufficient. But again, nothing I think compromises for the component position.
What do you guys use for your femoral neck fractures? Would you use this or?
Oh, I would not. I think that the cost is prohibitive, right? You take a problem like a hip fracture, which is a very common problem, and then you're trading, and this is in a pretty low demand patient population, and then you're going to put a very expensive implant in there that if you're really worried about stability, you're getting it for a femoral neck fracture. Assuming that they're not a young femoral neck fracture, if it's an older person, do a bipolar. If they're low demand, and then that solves the stability issue, and it's a much cheaper component. If otherwise, if you know how to put in a hip and you're confident about your component placement, I think that the rate of dislocation with 36 heads and total hip arthroplasty of dislocation from a posterior approach is not that high, especially the posterior repair. And from the anterior approach, it's probably less. If you're comfortable with that approach, do that. But I don't think a femoral neck fracture demands dual mobility.
Would you put in a cup that was convertible to that? So a cup that you could put a polyethylene liner in primarily, but if they did have problems with instability, then you could convert it to a dual mobility without having to revise that.
Yeah, I don't think that's an unreasonable thing to do. I certainly don't think that's unreasonable. The problem is that there's only one of those cups on the market. The rest of them are all kind of monoblock, and so that just depends on whether or not you like that cup. But I don't think that's a unreasonable strategy.
But again, the concern there is adds another layer of modularity. So I have a titanium cup, a cobalt chrome liner. So again, these are, and again, this is the cup I use. So these are things I consider. It'd be very easy to use, dual mobility with most cases, and not have to worry about instability. But it's just a little too early to say. We'll probably talk about organic corrosion and fretting and things that may happen with a very large head, torque transference, and all kinds of potential problems. But it is nice to have an option, I guess, for modularity.
Because I think the problem is the majority of femoral neck fractures are probably not fixed by total joint specialists across the country.
Yeah.
And so, like it or not, the rate of dislocation will be higher.
Sure.
So those people who are general practitioners or whatever you have it are going to be fixing these femoral neck fractures with arthroplasty. And I think that the kind of bimodal distribution of very, very sick patient going to die in less than a few years. So just put a hemi, or the 80 or 70-year-old that does a triathlon still. It's not that simple anymore. I think there's people who are kind of in the middle that are going to live for 15 years maybe, and they're still going to golf and do whatever. And so perhaps doing just a monopolar uni is not the right thing for you, and you don't do total hips, a day a week or something like that. So I don't know what your thoughts are for this modality.
Yeah, I think if you're in a group setting, you should save those patients that require a total hip for your partners that put in sockets a lot. Do the bipolars if you feel comfortable doing those. That's probably what I would do. But yeah, I think those are all fair points. But I would just caution that the person putting in a socket it doesn't feel comfortable putting in a socket for a regular bearing, maybe you shouldn't be putting in a socket for a unknown long-term outcome bearing either. You know, because that's what I'm saying. Like I think that there are a lot of guys that did that with metal on metal heads. They were thinking, well, I don't usually put in sockets, but hey, we got these great big heads now, let's do it. And they put in vertical sockets that ended up, you know, creating a metallosis epidemic. So, you know, I don't know that, you know, certainly wouldn't be a metallosis issue for dual mobility, at least that I don't think, but it may be another issue.
Another issue we don't know
Yeah,
about.
right. I'm kind of a 2 trends behind kind of a guy though, you know. All polytibias.
Do you know what the cost difference is between the two? That's one thing that wasn't addressed on the paper at all.
Yeah, I don't know. You know, Navis probably does. Yeah.
$400
$400 per implant.
for my system.
Between doing a bipolar and a
No, for a fixed bearing, you know, ceramic on polyethylene construct with dual mobility, it's about $400.
What do you guys more?
So Neil's got a case.
Yep, this is the case I did when I was at Northwest. So the patient was a 6-year-old female who presented to clinic with a several-month history of left hip pain, particularly thigh pain. And she presented 13 months after undergoing a primary total hip at an outside hospital. Her primary hip was complicated by an IND of a seroma, for which she was hospitalized for 2 weeks in the hospital getting IV antibiotics. When she came to clinic, we did an infectious workup, which was negative, and so she was scheduled for the OR for a revision due to likely aseptic loosening. And then she underwent a revision of her left femur to a cone conical system with a liner exchange, but the acetabulum was not revised at the time. So this is her pre-op imaging. And this is her post-op. So her post-operative course was complicated by 2 anterior hip dislocations in November. She was both times reduced closed in the emergency department at UW and was given a hip abductor brace for 6 weeks and increased precautions, but continued to dislocate that second time. So the decision was made to take her for another revision to a modular dual mobility system. So intra-op, it was a direct lateral approach. She had a lot of scar tissue and she was really obese, but a bigger cup was put in, a 42 millimeter MDM head and a 28 inner ceramic ball. And the cup was put in 43 degrees of abduction, 15 degrees of aneversion, and was stable at the end of the procedure. And there was a note in the post-op note that there was significant abductor damage at the time of the revision surgery. These are her post-op films. So follow-up, she was 50% weight bearing times 6 weeks with posterior hip precautions. And I think the last note was from February this year, and she was still stable with no dislocations and no precautions in full weight bearing. So these are just more papers about dual mobility. We basically talked about everything, but the main indication is for instability, and these papers talked about instability the most. And the problem with the literature in the U.S. at least is that there's not long-term follow-up. I mean, there's not even, I don't think, 5-year data yet. But so far, at 22 months, a series of 44 hips had no dislocations. And 88 at, I guess, for 5 years. That was the one with 5 years I could find had no dislocation, or 1 dislocation and 2 for aseptic loosening. So the advantages, like we talked about, it's got a lower rate of dislocation and it kind of maximizes the potential of a small diameter head with low friction and a large articulating surface. The disadvantages are the cost. There's no long-term data. And then the increased motion. That was kind of for the earlier implants that were used in Europe and not so much the implants that are used in the U.S. now for neck impingement. That's pretty much it.
Good job. Okay, why don't we move on to, and this is kind of, I ordered the papers this way, but so we just talked about all the good things about dual mobility. The next paper we're going to talk about is how have alternative bearings and modularity affected revision rates in total hip arthroplasty.
Alright, so I have this paper, Clinical Orthopedic Research 2014. So this paper, its primary purpose was to look at whether or not these alternative new bearings have decreased anything with revision rates in primary total hip arthroplasty. The method was a systemic review of the literature of level 4 evidence or higher, with at least 5 years of follow-up. They were able to pull about 32 studies of metal on metal, 19 studies of ceramic on ceramic, and then 20 studies of modular stem designs. They used a Medline and an EM-based search to do their review, and their primary research parameter was survivorship of primary total hip arthroplasties. Their summary result was basically that there was no evidence of decreased revision rate with any of the alternative bearings. So in the metal on metal, they had about a 6% revision rate, 2 to 14% of the femoral stem, 3 to 100% of the acetabular components, and then the 10-year survival was anywhere from 82 to 100%. These are pretty similar with the other studies of ceramic on ceramic, with the 10-year survival of about the same, 84 to 100%, as well as the modular stem designs. They basically concluded that there's no evidence to support the alternative bearings, and what they found was that metal on metal actually had a lower survivorship. The reason they did this study is because as technology progresses, we continue to come up with new developments, and because we do have these problems in arthroplasty, the goal with these new implants is to try to address these issues. But the downsides is that with stricter limitations with Medicare and Medicaid reimbursements, and a lot of these bearings have increased costs associated with them. So the major point of the study was to figure out, is there a benefit in primary revisions based on these alternative designs? And based on their analysis, there's not.
So I think the data that they looked at was divided between clinical studies with greater than 5 years of follow-up or registry studies with greater than 7 years follow-up. And when you're kind of pooling level 4 data, I think I rely more on registry data for this type of stuff. I think it's a little bit more reliable. It's a little less bias. I don't think this meta-analysis, just from a grading of a paper, was done nearly as well as the one on polytibias in terms of the methodology and the statistical analysis. But I think that the paper highlights a few things. One, large metal on metal heads do bad. 2, modular necks also do bad. And so, I think the question that begs is, there's certain large head metal on metal components that are out there that have good survivorship, like a Birmingham resurfacing when done by the right people. I think that, so it begs the question, if it's not happening on the bearing surface side, where is this increased rate of failure occurring? And then when you combine that data with what we know about modular necks, right? It really sort of makes you start thinking about the head-neck junction, right? And so for me, when I read something like this and I sort of want to ferret out sort of the key points, I think it tells me that, head-neck taper corrosion is a real thing. And I think it has to do with the size of the heads we're using on tapers, and certainly I think by adding a dual taper for these modular necks, that also accelerates the incidence of that happening. And so, and then the other thing I would take out of this is, while the ceramic on ceramic didn't seem to provide any increased survivorship, it does impart a risk of a catastrophic failure mechanism through fracture of a ceramic liner, which is a horrible thing to have to deal with. So those are kind of some of the main take-home points I took out of this. I don't know, Nav, when you read this, like what your thoughts were, but those are
interpreting the
Yeah.
I guess the broad pool of data. I would agree. I mean, registry data is somewhat more powerful when you kind of accumulate weak data. It's not truly a meta-analysis. I mean, willful data accumulated is not really what a meta-analysis is designed to do. Having said that, this type of study is not really amenable to randomized controlled trials, even though those have been done. But all this data, I think, is good at identifying problems. But because the standard is so high, for the gold standard, which is still metal polyethylene, it's much harder to distinguish, small differences. Even particularly with survivorship, given that 20, 25 years survivorship should be close to 95%, if not higher. So I think maybe we need different tools to distinguish, if there are clinically relevant differences between these materials. And this population may not be the population that Adam and I treat, or certainly that you treat. There's lots of 20, 30-year-old patients with washed out hips that need to have hip replacement. So they likely exceed the expectations of the implants that were put in 30 years ago. So I don't think we should, by any means, discredit novel technology, but it's just harder to, elucidate what those differences are.
Yeah. And the other conclusion that the authors came to is that, when we are releasing sort of new technology to the market, that the limited release should be, held on for I think they recommend 5 to 7 years, which I think is, reasonable, right? We're talking about results, and we want results in our patients, like Nana says, to last upwards of 15 to 20 years, so, had we waited a little longer on the metal on metal, maybe we would have prevented some of that from happening. So I think that's also an important take-home point from this article. But we're going to move on to the last article, which is no differences found in bearing-related hip survivorship between patients with ceramic on highly cross-linked polyethylene bearings compared to patients with ceramic on ceramic.
Okay, so this is a paper that I prepared. It's written by 2 authors. The surgeries were performed by a single surgeon in France between 1997 and 2002. This study was published in the JOA in 2014, so last year. It's a very short, very simply designed paper, which I think oftentimes the best papers are the most simple. So there's not a ton of detail to go into. It's a retrospective study, but a very good, very high volume retrospective study with a lot of follow-up. The surgeries were performed by a single surgeon at a single center with the goal of comparing hard-on-hard bearing ceramic on ceramic to the alternative being ceramic on polyethylene. It should be noted that the polyethylene, even though this was done back in, the surgeries were back 10 to 12 years ago, was a highly cross-linked rather than ultra-high molecular weight polyethylene. Their null hypothesis was that there would be no difference in demonstrable wear or survivorship of these 2 different bearing couples. And they were looking to see if any differences did exist with long-term follow-up. As I mentioned, these are high volumes of cases in each of the 2 groups, 228 cases in the ceramic on poly group and 447 cases in the ceramic on ceramic group. The paper describes them both as consecutive series, although they're performed by the same surgeon over the same time frame. So that's something that I don't necessarily get, but I guess we'll go with it.
It's France, man. It's France.
Yeah. As I mentioned, it's a simple retrospective study which gets its power and its credibility through its length of follow-up and size of numbers in terms of case volume performed by a single surgeon. This surgeon with greater than 10 years follow-up was able to look at 228 consecutive ceramic on poly and 447 consecutive ceramic on ceramic. Looking at all of the descriptive characteristics, the groups are very similar, and looking at the wear rates between the two implants measured with precise radiographic analysis, both groups demonstrated virtually negligible wear. So that was one interesting point to raise, is that the ceramic on poly group wear was extremely negligible, clinically insignificant compared to the wear rates of the ceramic on ceramic group. In terms of their primary outcome, which is survivorship, both groups did extremely well. The authors broke down their survivorship to revision performed for reasons that can be attributed to bearing choice, and then revisions overall. When looking at revisions performed only due to bearing-related issues, both groups were 98%. The metal or the ceramic on poly group had a higher overall revision rate, which the authors attributed mostly to increased dislocations. And I think the reason for that is because, for whatever reason, for the obvious reason, ceramic on ceramic groups were much higher femoral head sizes overall than the ceramic on poly group. So I think that contributed to a little bit of the increase in dislocation rate for the ceramic on poly group. But overall, survivorship analysis for revision reasons related to bearing choice, the groups both did extremely well. And again, this is 10+ year data. I think their conclusion was a reasonable one based on this data, in that ceramic on poly is a viable option compared to ceramic on ceramic, and certainly more cost effective. The one caveat would be that there's a tendency to use smaller femoral head sizes in a ceramic on poly group, but at least according to this well-designed study, you're not going to get an appreciable amount of wear in ceramic on poly to make you concerned for significant osteolysis-related phenomenon, at least up through 12 years. And you avoid some of the catastrophic complications that we talked about last paper, such as the unlikely event of ceramic fracture.
When I read this paper and was thinking about this paper, and what I've kind of thought about ceramics on ceramic in the past is that the person who you might want to put a ceramic on ceramic in would be somebody who's 25 years old and you're really looking for a home run. So something that might last theoretically could last forever, right? And that's the benefit from that. And I was just wondering what you guys thought about one, who you would consider it, knowing that this paper shows it's not any difference at 10 to 12 years. And two, how would we actually figure out if this might be the solution without having 50-year follow-up data?
I think that's a good question, because with 98% survivorship for ceramic polyethylene or metal polyethylene, in order to discriminate a clinically relevant difference, as a categorical variable, you have to do our analysis, but it'd have to be tens of thousands of patients to distinguish, something that's actually clinically relevant and change someone's practice. So clearly you can't do that without either, multi-centered, involvement. So we typically just rely on kind of biomechanical data, and there's value in that in itself. But the reality is, when we've used these technologies in vivo, it hasn't necessarily replicated what we found in the lab. Metal on metal, as we talked about, ceramic on ceramic, in terms of wear properties, and, coefficients of friction, hydrodynamic lubrication, all these things, in theory, could lead to minimal wear. Certainly, much less so than a traditional bearing surface. But to clinically prove that requires huge amounts of patients, and typically one can't discriminate the complications until you've introduced into a patient population. So again, these are complications that we've created in orthopedics. Metallosis, whether it be metal-metal reactions, adverse tissue reactions, ceramic fractures. All these things were introduced with good intentions, but created complications that didn't particularly exist. So in terms of embracing new technology, I think you have to keep your mind open and not discourage new processes. But again, the standard in total hip replacement in particular is so high, that there's really a safety burden that I think you have to pass when the data that we currently have, which is 20-year data, is already so good. So at least in my practice, I use ceramic on polyethylene for all patients. I think there's enough, current data to support safety and supports, efficacy. And again, there's new technology that's available. I think you just have to pass the gold standard and embrace everything with care.
Yeah, I would never use. I don't think I'd ever put in ceramic on ceramic bearing, just because there's ceramic on poly. Does so well, even in young active patients. I just don't think that I would consider it. I think that you introduce squeaking, you introduce potential for ceramic fracture. Also, like the data on 50-year data on ceramic, at least the current state of ceramic on ceramic, really doesn't exist. So it's like we're talking about unicorns. You know what I mean? Like it hasn't happened. So I don't know why everyone thinks it's gonna happen. We don't know what's gonna happen to ceramic in 30 years. There's phase transfers. Things happen in a body that we can't really account for. And so, but I do know that there's good 20-year data on highly cross-linked polyethylene that shows it does well in a young active population. So I wouldn't mess with that.
The ceramic on ceramic came out kind of when we didn't know anything about the results of ceramic or metal on highly cross-linked polyethylene. So that's why, for example, I probably did a couple hundred ceramic on ceramics, and I don't know of any of them that have had a failure.
Yeah.
However, I quit doing it because there was all these people, not in my practice, but other practices that were squeaking.
Yeah.
And the last thing I wanted to do was have people who squeak. And so, and then the data started coming out with ceramic on highly cross-linked polyethylene.
Yeah.
And I think that, are you doing it in all ages then?
I do.
And since the trunionosis data has come out, I've gone to ceramic on highly cross-linked polyethylene on all ages too. I don't know what other people think.
Yeah, I mean, it depends on the very low demand.
If they're 90 years old.
Yeah, exactly. Then I usually
trunionosis is going to be an issue in their lifetime, right?
Right, but
They have 20 years to live.
I think normally I would say like 75 and up to 75 in a female, up to 70 in a male, maybe. But it's not. It depends on their activity too. I take a lot of things into account. That's just based on cost analysis data, really, that was presented this past year at AUKUS, where they looked at the cost of potential revision over time, secondary to wear, and things like that. The other note, though, is that one thing that would push me more to doing ceramic in all ages is the fact that if someone does come in with a painful hip and they have a metal head, it costs money to work them up for, and usually if they're negative for infection, I will work them up for corrosion and an adverse tissue reaction, and that's an expensive workup. So, it may work out, depending on how you do the cost analysis, it may work out that ceramic is a better bearing surface for all ages. So,
I think minimizing variables is kind of important, at least in my practice. I just want to, the way I was trained at least was the same thing every time, every case. So that I know at least if I did the same job and I'm happy with the component position, if the patient's unhappy, it's a little bit.
You're talking to a guy who switched to direct anterior at age 60.
Right.
I did the same thing, and we weren't having any trouble with posterior approaches. They did great.
Right.
And you switch.
they're flashier billboards though with the anterior approach.
That is one.
Yeah.
Gotta get. Yeah. If you can't beat them, join them.
There you go.
I would always think about modern highly cross-linked polyethylene as being significantly better in terms of wear characteristics, but this paper brought out for me just how impressively low the wear is even with modern poly. They quote a 0.01 millimeter per year wear rate with highly cross-linked poly. So these people who have had these hips in for 10 years, I guess you can question the validity of measurements of their software that they're using, but they're quoting a 1/10 of 1 millimeter wear rate total after 10 years. With ceramic on poly.
0.01 millimeters, so 100.
0.01
so 100
per year. So after 10 years, it's been 1/10 of 1.
Do you guys know what the cutoff is for osteolysis, like clinically relevant osteolysis? That's usually an OIT question.
Millimeter per year.
It's 0.1 millimeter.
Yeah, that's what they use.
So it's so it's
There's a factor of 10
factor of 10 lower. Right. So, well, I think we should take a 5-minute break, and then we have a really exciting talk coming up to talk about an additional bearing surface to think about. I think the one I use in knees currently, which is oxinium, and it is a little bit different than the sort of the standard ceramic bearing, and I think it will be very educational to highlight some of the differences between standard ceramic and this bearing surface. But we should take a 5-minute break first before diving into that. So.
Yeah.
This is so you're gonna see this once you go into the next slide of
That's swamped wrong.
It really comes down to memorizing but you've also got your slide there. That works better for you, and you know what's coming up next.
Oh, I know.
Keep getting stuff.
Yeah, I mean, even now, it's just moved around. I'll count on one. Here for it. I'll take it back here. Good.
First one had drum barrel aged. I can't remember. It's good.
So, There's like a fight. The guy's got an Adrian brother. And then he's not interviews. We're gonna have a well, I didn't actually. I'm also Alright guys, if you have mind taking your seats, we'll get started here. Hey, Philippi. Hey, Todd, you want to turn this jazz? You got it. I know it's you too, bud. I said KG. I said Alright, okay, so for the final talk here, we have a guest speaker, Gordon Hunter. Thanks again for coming out all the way from Memphis. He's going to talk to us not about a different bearing material, which I think is, it's good to get an engineer's perspective on in terms of the manufacturing and different, material properties that certainly I am not very well versed in as I should be because I use it and it's a good re-up for me. But I think it will be interesting and hopefully thought-provoking for you as well in terms of the different properties that this has to some of the other materials we use in orthopedics and potential clinical applications thereof. So, Gordon, thank you so much.
Thank you very much for inviting me. I've been working with Smith & Nephew for over 21 years. My background is in metallurgy and materials engineering. I figure out how to make things. It's my background. And Smith & Nephew brought me in to work on this technology. They had the invention in the lab, but they didn't know how to put it on the manufacturing floor. And that was my contribution, was to help figure out how to bridge that gap. And so I'm going to talk a little bit about it. I'm just going to touch on a wide variety of subjects. Every one of these slides has another presentation behind it, if not 2 or 3. So forgive me if I seem like I'm going very quickly, and if I lose you, don't worry about it. You'll pick up in the next slide because it'll be a new presentation. So what we're talking about is the black component there. It is a zirconium metal component that has been oxidized to produce a ceramic surface. We'll talk about why and what all of that means. And we've mated it with our cross-linked polyethylene to create something that we call Veralast, just so that we have the terminology straightened out. The issue that we're trying to deal with joint replacements with bearing couples is longevity. We're trying to reduce wear to improve longevity with patients. And even with the bad old days of gamma and air sterilized poly, most of the patients never need a revision. So there's a large variety of low demand patients that will do fine no matter what materials put in them, and we need to worry about the designs and other issues like infection. But there is an increasing group of high demand patients, particularly young patients who are going to live longer, who are heavier, who want more than just pain relief. And we got to keep up with these folks to give them a joint replacement which is going to last the rest of their lives. So that's why we work on bearing technologies. And the two big issues that we're trying to do once we get rid of the problem of polyethylene falling apart, we have to deal with friction and abrasion. Friction pulls off polyethylene particles, that's called adhesive wear. Abrasion grinds them off, pushing them off. We call that abrasive wear. And those are the submicron particles associated with osteolysis. And if we can reduce those, we believe we can improve implant longevity in general. Not for any specific patient, but for patients in general, those that are going to be challenged by wear, we're trying to reduce that limitation. Cross-linked polyethylene is the way most of the companies, in fact all the companies now, have dealt with this issue most effectively. We're looking at here a knee simulator test, looking at the wear rate of polyethylene against a cobalt chrome component in terms of cubic millimeters of polyethylene loss per million cycles. And for a typical patient, a million cycles is about a year. And you can see with the, on the left, the non-irradiated polyethylene, our gas sterilized conventional polyethylene. You can see what the wear rate is and how it drops as you irradiate the material and increase the degree of cross-linking. And for us, we focus on 7.5 megarads in the knee. It's a good balance between mechanical properties and wear properties, and we get that sort of a wear reduction in this particular test, about 73%. And if I was working for another company, I would say thank you very much for dinner, and I'd leave, because that would be the end of the conversation, particularly in knees. However, it ignores entirely what's going on the other side of the bearing couple. And the best polyethylene in the world that's up against a cheese grater, as somebody once said, is still going to wear. So, cobalt chrome does roughen. Every single retrieved component we've looked at has scratches. Every single study that mentions the condition of the cobalt chrome component in the simulator test indicates that they're roughened, even in the absence of intentional abrasives. It just happens. There are lots of sources for these hard particles, and when they drag through the surface, they plow the component. They raise a peak and create a valley, not just removing material. And it's those peaks that do the real damage. And a peak of 1 micron, which you can't see or feel, like the one that you see this image of, increases polyethylene wear locally by a factor of 10. So we want to minimize this kind of roughening if we're going to try to really optimize our wear performance. So what does that look like on the simulator result? So we took these pristine components and we tumbled them in an abrasive to take them up to the highest level of roughness that we see in retrievals. And these are not retrievals for failed polyethylene. These are just normal retrievals, some of them for infection. In any case, that's where the curve goes to if you roughen them up. And interestingly enough, for the cross-link population, you're pretty much undoing all the advantages that you had by going to cross-linking in terms of volumetric wear. And one thing I will caution you about when thinking about limits of polyethylene wear associated with osteolysis, not all polyethylenes produce the same kind of particles, and we know that cross-linked polyethylene produces smaller particles, which are more reactive. So the same wear rate with cross-link may be more inducing of osteolysis than that same wear rate with conventional poly. So you've got to be a little bit cautious about how you treat the data. Anyway, a typical patient is going to be somewhere between those extremes. I'm not saying that every patient is going to be at the top. Very few of them are at the top, but also very few of them are at the bottom. Most of them are going to be somewhere in between. But what we can see from this is with the conventional polyethylene, the wear rate's about double. But with the cross-linked polyethylene, it's more like 6 or 7 times higher. And what we are learning from this and from other studies like this is as you challenge cross-linked polyethylene more and more, it behaves more and more like conventional polyethylene. Still an improvement, as you can see here, about 30%, 40% reduction. But it's not the 70 or 80% reduction that we're expecting from cross-linked polyethylene. So what we're trying to do is to address this limitation of the cross-linked poly. And it's not new. Every single company, every single researcher who's been working on bearing couples has known all along that this is a limitation of cobalt chrome. Works for most patients, but for the high demand ones, it does have some limitations. And so they've been trying to fix this for years. One way they do it is ion implantation. Those of you who have heard of L-Fit from Stryker. Diffusion hardening, Hinidium from Zimmer. These are hardened metal surfaces, they're metal treatments, but they're very thin. They're inferior to ceramics in terms of hardness, they do corrode, and they're short-lived at best. Ceramic coatings like titanium nitride or titanium niobium nitride, that's Biomet solution. Diamond coatings, nobody's commercialized that yet. These have limited uniformity and durability, and in particular with the ceramic titanium nitride coatings, they tend to wear off, even just abrading against polyethylene. In simulator testing, typically 3 to 5 million cycles, and they're gone. And you've got all this hard debris in the joint that can come back and attack the unprotected metal surface. And then monolithic ceramics, which have been by far the most successful of these alternative technologies. Zirconia, not so successful, but alumina has been pretty successful. And now we've got the pink delta, which is a composite between aluminum and zirconia, which seems to have some promise to it. We're getting better and better. The fracture risk is going down all the time, but it still happens, as we talked about with the liners. If you do have one of these break, it is a very complicated revision, and the patient does not have a good outcome long term. So we wanted to go a different route. So we focused instead on zirconium metal. And this is the alloy that we're using. It's got a little bit of niobium and a lot of zirconium, about 2.5–8% niobium. It looks like any other kind of metal. The reason we chose these is because this is a non-essential element. The body doesn't use it for anything, so it doesn't regulate it. It doesn't have any kind of disease syndromes associated with it. You can't overdose, you can't underdose. You can get metal toxicity, but you have to go to very high levels of ions, and they don't naturally inhabit the body. So it's a good choice, but in addition to that, the zirconium, like titanium, very biocompatible, but unlike titanium, zirconium, when you heat it up in air, oxygen diffuses into the surface. This will happen with all metals, and you get that enrichment. This is the tinidium process that Zimmer uses, for example. And you just get a hardened surface that's very thin and it's still metallic. If you keep going with this process, though, with titanium, you produce a white powdery oxide that flakes off the surface like rust flakes off of steel. But with zirconium, you actually cause transformation that produces a high-integrity oxide, what we call a scale. So you take this zirconium matrix of metal and you start putting oxygen atoms into the crystalline lattice with it, and you cause a transformation from zirconium metal to zirconium plus oxygen, or zirconium oxide, which is a ceramic. So you have a ceramic on the surface. Wherever it's in contact with polyethylene or the soft tissue, it is a ceramic and it behaves as a ceramic. But if you cut it in two, unlike a ceramic component, you see internally it's all metal. 5 microns is where we stop the process and the end of the process, including polishing and all of that. 5 to 6 microns. Too thin to be seen by eye in cross-section. It's too thin to hold the load. So as this gets loaded, as this metal gets loaded, it bends and flexes like a metal will. And the ceramic has 2 choices. It can either peel off and flake away like rust off of iron, or it can remain attached. This ceramic oxide stays attached. It's a very unusual material. So why does that happen? This is a microscopic image. The white bar down in the lower left corner is 0.2 microns. So at that kind of magnification, the oxide extends off the top of the screen. We're looking right at the boundary there between the metal and the ceramic. Several important features. One, the crystals, the ceramic crystals within the oxide are pointed toward the surface. They're self-supporting like the bristles on a broom. They're not going to rub away. Titanium nitride coatings, when you coat them onto the surface, you apply it to the surface, you can rub them off one layer at a time. This won't do that. These crystals are also interlaced. They're interlaced between the metal and the ceramic. They're interlaced within the ceramic. If you squeeze your fingers together like this, it's very difficult to pull apart. Part of the reason why it remains such high integrity. And in addition, these are very small crystals. We consider this a nanostructural material. While the individual crystals are brittle, the boundaries between them allow a little bit of shifting. And there's so many crystals all the way through this oxide that as the metal bends and flexes, the ceramic will bend and flex with it. We have an effective ductility. And so you can get some very interesting behaviors. It won't shatter like a ceramic will. If you take a head like this and you put it on its side and crush it with 10 tons, it will oval out. It will not shatter. So if you're dealing with a revision case and you're concerned about the condition of the taper, put this on the taper as long as it will lock down, and it's important that it locks down. As long as it locks down, it's not going to shatter like a ceramic head might. So it's an option for that. This knee here, we loaded it with 4,500 pounds on that condyle and bent it over. Not to say that you have any 2 1/4 ton patients, but just showing you that the damage mechanism, the failure mechanism is bending, not shattering. And if you rub it in here, it'll feel smooth, but if you rub your fingernail right in here, you'll feel the cracks. And what happens is as that has bent away, you've pulled the oxide apart, but it didn't pull off. It still feels smooth, but your fingernails feel those cracks. Point being, it's damage tolerant. The oxide is actually more firmly attached to the metal than it is to itself. It'll pull apart, but it will remain attached and continue to protect the metal underneath. And as a result, we don't have to worry about brittleness. So we design it the same way we design cobalt chrome. It's interchangeable, no surgical technique changes. You can swap back and forth for demand matching to get better economics at your practice. It matches with all the same components and all the same instruments. So you have all that surgical flexibility associated with the cobalt chrome components, but you have it with a ceramic counterface. And it won't rub off. This is a test, 10 million cycles, now 10 years of a chip of bone cement stuck in the polyethylene rubbing against the counterface, 10 million cycles, does not go through the oxide. 1 million cycles of this test went through the titanium nitride coatings. So you can see that it's not going to rub away, it's those bristles holding together. This is cobalt chrome in the same test, pretty easy to see the wear track, pretty easy to see how much the bone cement's went away. 4,900 times more volumetric loss from the coupon here than with the oxinium. 160 times more roughness. That's abrasive wear by fingernail. And you can see the fluid is full of debris and discolored from the ions. And the oxinium virtually pristine. So the material is going to roughen less. That will reduce abrasive wear. It also reduces friction, which reduces adhesive wear. Oxide ceramics have an additional benefit is they're more wettable. Fluids tend to spread out and give you better lubrication, which reduces friction, which also reduces adhesive wear, whereas the fluid tends to bead up on the metals and give you a little bit higher friction. So when you put this into a knee simulator, this is looking at conventional polyethylene, same design of femoral component comparing cobalt chrome to oxinium. The far left curves there show you a 42% reduction by substituting the cobalt chrome with the oxinium. But those are under benign kinematics. If you increase the rotation and introduce some varus malalignment, the difference in wear rate jumps up to 61%. In the study from, where's my graph? There it is. If you look at the other graph, this is from Clemson. They tumbled the components, took them up to the highest level of the roughness we see in typical retrievals. Now, instead of 42%, the difference in abrasive wear is 82%, because of the difference in the amount of roughening that occurs with the surface. We get anywhere from 40 to 90% difference in volumetric wear with non-irradiated poly. It's more complicated with crosslink because it's harder to measure, but we see the same kind of rates when we get up high enough to measure it. And that's both hips and knees under a wide variety of conditions, but the important thing is the higher the demand of the test, the greater the relative performance. And if you think about what you're trying to do with your patients, your low-demand patients don't need help. They need safety. We don't want to hurt them. And this isn't going to hurt them. If anything, it'll help them a little bit. But they're going to have their components for the rest of their lives anyway. They don't need a lot of help. High-demand patients that are going to be challenged in terms of longevity are the ones that are going to get the greatest wear benefit by using Oxinium, and particularly in combination with crosslink, which we'll talk about in a minute. And then there's this additional benefit that came as a bonus by choosing this zirconium metal. We have very low nickel content, difficult to measure, no cobalt, no chrome. These are all sensitizing materials. They can spark allergic responses, whereas zirconium, titanium, much harder to spark an allergy. And we're also reducing the amount of metal ions produced. And I can't really go into this in detail, but we have had a number of doctors who use this for their metal-sensitive patients and have had good results. And that's about as far as I can take that conversation. So we've got all these advantages with Oxinium: less roughening, less friction, less adhesive and abrasive wear, strong and durable and not brittle. So we make it in the proven designs. We've got the surgical flexibility and these additional benefits from biocompatibility and reduced metal ion concerns. We've been using this now for over, 17 years in the knee and 12 years in the hip. We have over 1 million of them implanted. Patients are doing great. They're doing at least as well as their cobalt chrome counterparts. Of course, in that time period, with modern polys, we don't expect to see failures. We don't expect to see longevity challenges yet. So we got to continue to follow this. We can say a couple things from these studies, though. One of them is it's safe. This is 10-year follow-up from Innocenti's group looking at G2 knees, both CR and PS, and he's getting a 97.8% survivorship at 10 years, which is at least as good as what we see with cobalt chrome. So we know that it's safe. It also appears to be effective, although we're, school's out until we get all the clinical results. These are some short-term retrievals, 1 to 3 years out, revised for things like infection or unexplained pain, malpositioning from HSS. And they match them for patient conditions and conditions of the revision. Just looking at the surfaces, 92% fewer wear features on the Oxinium compared to what you see with cobalt chrome. 31% fewer wear features on the associated polyethylene with Oxinium compared to the cobalt chrome. I can't conclude that it's lower wear, but the features are less, and it's backing up what we are seeing in the laboratory. So once again, checking back, is the laboratory data lining up with the clinical experience? And so far the answer is yes. So we are optimistic about where this is going. Now, if you match this with the cross-linked polyethylene, you get what we call Verilast. And here is the data in the knee simulator again, looking at pristine cobalt chrome and pristine Oxinium. And you can see about a 40-50% wear reduction with the Oxinium relative to the cobalt chrome, as we had seen from the Scripps study. We see this over and over again. And you can see that at all conditions, it's better than the cobalt chrome. But now we tumbled the components, and you remember this cobalt chrome curve from before. We tumbled the Oxinium. In this particular study, the curve lay right on top of each other. Typically, it's about 5% higher. So even at 5% higher, remember that the typical patients are going to be somewhere between those two, the solid curve and the dotted line curve. Those high-demand patients are going to get better wear resistance with the Verilast technology than anything else that's on the market.
I have a quick question for you.
Yeah.
Do you know what the radiation dose is for your standard poly?
We don't radiate standard poly.
So
it's gas fumigated.
So it would be zero.
It's
right?
the zero. It's over on the zero axis, and that's where the data is.
So that's standard poly there.
That's our standard poly.
Yeah.
Most people, their standard poly, if they're still using it, is gamma inert, which is about 3.5 megarads, 3.5 megarads. The 5 that we've got the data for there, that is what J&J used to have as their highly cross-linked, their Marathon. They now are using higher levels than that.
And you said that with pristine cobalt chrome on highly cross-linked, your rad dosage to poly is what?
7.5 for the knees.
7.5.
10 for the hips.
So looking at the data there, 7.5 with pristine cobalt chrome with 7.5 is pretty much about what standard poly is with oxinium, very close to it.
Well, actually, the real comparable is about 5.
5.
So what we've been saying.
Because I use oxinium.
You're off my script now. But,
Right.
all right. So since you're asking, I'm going to burn the time now.
This is selfish.
Okay.
But
what we've been saying is, if you are for some reason you're very conservative about cross-linked poly and don't trust it in the knee, God bless you if you're conservative.
I'll use an all poly component. You guys haven't made highly cross-linked polyethylene, all poly tibias yet.
With reason.
Yeah.
Because mechanically, there are issues there that we still have to sort out.
Sure, but that's why.
So that's what it's the mechanical challenge with the cross-linked poly that we're particularly worried about. So if you are going to use the conventional poly because you want to use an all poly, and that's a legitimate reason, you can get the same results with oxinium against our conventional poly that someone else would get with cobalt chrome against 5 megarad irradiated polyethylene. Which is, as I said, the old Marathon.
Sure.
And then if you consider further what happens if you start challenging the system, I'm showing abrasives here, but I can throw in load, I can throw in motion patterns and more challenging kinematics. The oxinium is going to remain low, where the cobalt chrome is going to climb more.
Okay.
So in those cases, you can see that in sometimes you're going to get better results with oxinium and conventional polyethylene than someone else is going to get with cobalt chrome on crosslink, even 10 megarad crosslink or 13 megarad crosslink, which is poly. We're still going to get better wear rates.
Okay.
Now, whether that translates into lower particle loads and better longevity, less osteolysis, we got a lot of pieces to put together, but all the benefits remain there. We have the same approach with Verolast for hips. Again, it's 10 megarads instead of 7.5 because we're less worried about the mechanical challenges. And just as an example, all the wear curves all look very much the same as they do with the knees. This is a 45 million cycle test, 30 years in a young active patient. This is activities of daily living, so not only is it walking, it's jogging, it's rising from the bed, it's climbing stairs, and all sorts of interesting things. And when we do this test, the conventional materials are the blue curve over there, they're running away. The cross-link on cobalt chrome is the middle curve, and the Verolast, the oxinium against cross-link, is the lower curve. And you can see when you're about 5 million cycles over on the left, it's hard to distinguish, but as you get further out past 10 million cycles, 20 million cycles, you can start to distinguish the difference in wear. It becomes even more dramatic if you look at wear rates, which this is total wear. And so that was very important to us. But after this, there was a big issue about taper corrosion and what you call tremulinosis, which I would argue is a bad word. It's not the trunnion that's causing the problem, but it's metal ion issues. And one of the things we found out is that while cobalt chrome on titanium does exhibit a crevice corrosion in almost every case, the oxinium was pristine. We don't see the taper corrosion issues with oxinium. And in fact, as it turns out, oxinium inhibits crevice corrosion galvanically. And I can't get into all the details, but it's even superior to what ceramics can do. Because best ceramics can do is be neutral. They can't protect anything. They just don't contribute metal ions. But you can still get metal transfer. You can still get fretting corrosion going on in the taper. We just don't see it with the oxinium. And that's another whole 20-minute presentation. And the last thing I will leave you with is this Australian registry results. Every patient in Australia is required to be registered. These are the hip results, and they've broken it down by bearing combination. I won't belabor all the details, just to note that the best revision rates are statistically significant and shown to be what they call ceramicized metal line processing poly, which is our Veralast. Now, I'm not going to sit here and tell you that those better revision rates are because of the bearing combination, not at less than 10 years. One of the things that we have to say is the other curves are all comers. So there's some bad stem designs mixed in there, there's some bad poly, and there's some bad surgical techniques mixed in with these. And that will tend to raise the numbers. But with the Smith and Nephew combination, there are 3 basic stems in Australia, and the 2 cups, reflection in R3, our crosslink and our oxinium. Whatever is going on there, we've got a great design, we've got good surgical technique, and we've got good materials. Because we're not encountering the same kind of failure mechanisms that's causing all those other curves to move up. So if you put it all together, if you eliminate each of the sources of limitations to longevity, you can improve implant survivorship, and that data is showing it right there that Smith and Nephew has got a combination of that in total hips. So, and we're going to continue to watch that curve as it continues to move to the right over time, but I can tell you right now that the registry people told us it was going to converge with the others, and in fact it's continuing to diverge as we get more and more patients moving further out in time. Very interesting results. And that's it. Thank you very much for your attention.
Thanks. All right. Well, I just want to thank everyone again for coming tonight. Thank you to the residents, especially for the presentations and review of the literature. Thank you, Gordon, for coming out. Thanks to our sponsors for the evenings with the Nephew. Appreciate it. Have a good evening.